name is Christian Bravo, if you don't know me. A Robinson County MS paramedic, FTO technically, and when we cover pharmacology, specifically cardiac drugs. So when we go how to treat certain underlying rhythms, and not necessarily 12 leads because you don't really treat STEMIs, but you want to focus on underlying rhythms. So we'll go over cardiology today. If you have questions or concerns, let me know. If I speak too fast or not long enough, please let me know. If you have questions, feel free to ask, raise your hand, and I'll try to follow you. Any clarifications, I'll do my best to clarify anything. So, our topic is electrophysiology. When we talk about the classification of drugs, this is Van Gogh Williamson's his classification of how to categorize it. You'll see different categories in a minute. Antihypertensives and hemostatic agents. So cardiac function is going to depend on adequate amounts of ATP, amounts of calcium, ions in the body, and coordinated electrical stimulants. Now, for the amounts of ATP, we focus on maintaining the electrical chemical gradients, the propagate of action potentials, and power muscle contractions. Calcium is a glue that links all your electrical and mechanical events. So in your body, you know, you got different level electrolytes. So you got calcium, magnesium, potassium. Those three work together to specifically focus on the heart itself. They all have the specific purpose, but most of the time, if one's elevated or de-elevated, the other two more likely has some type of abnormal level. We can't obviously check it in the field other than looking at some 12 leads, but we don't really have blood work for that. So the heart is capable of autotomicity. What does that mean?
It can propagate its own impulse.
Right, it functions by itself. You don't have to do nothing. You don't have to tell your heart to beat like I need to beat now. It beats by itself. And there's two types of myocardial tissue: contractility and conductivity. One's the physical aspect of it, like the heart pumping itself, and the other one's the actual electrical impulse. And the impulses travel through the action potential superhighway, which y'all know is what? Say no, if you know.
Yeah.
Follow his Purkinje fibers. See, it's just can't really label it, but it's SANO, if you know. Follow his Purkinje fibers at the bottom. So if it's what's your normal heart rate for SANO?
60 to 100.
If you know.
40 to 60.
Follow his
40 to 60.
and Purkinje fibers.
20 to 40.
Right, if it's below, if it's here down, that's is it atrial or is it ventricle?
Ventricle.
What does this refer to as?
Sinus.
What's the SANO is your pacemaker.
Yeah.
Right, that's what shows how your heart beats and how it functions. There's two types of action potential: fast potentials, which is found in contractility tissue, and slow potential, which is found in your SA node and the AB nodes. So this is just a small diagram of how phase 1 goes down to phase 2, phase 3, and phase 4, where it starts to contract, pumps the blood, and slowly starts to release and do that depolarization. This is also controlled by sodium. Sodium is a big impact when it comes to the heart. A lot of people don't realize kidneys really control your blood pressure, not your heart. So that's why people who have kidney failure or on dialysis tend to have really bad blood pressure, because they have a poor function of getting rid of that sodium in their body. So phase 0 is that sodium influx, your fast sodium channels. Phase 1 is your potassium influx. Phase 2 is your plateau of your potassium, where it kind of reaches its max potential. Also that's where your calcium influx comes in as well. Phase 3 is also another version of your potassium influx, and then phase 4 is that resting membrane. So it starts to contract, builds up to its peak, and then it slowly starts to work its way down where it's kind of relaxing. And it's all done within like a few milliseconds. This is an example of it going up, reaching its max, slowly going down to relax, and repeating that same process over and over. It's constant. The average lifespan is 72 years, roughly. Your heart beats about 60 to 100 times a minute. By the time you're 72, you're thinking over like 3 36 million times. Your heart's probably beat in its lifetime without any physical exercise or anything like that. So your slow potential, it depends on your calcium channels, your slow channels, where it goes up, reaches a point and comes down. This is where your self-depolarization is when the heart's starting to kind of relax. This is also responsible for automaticity. Phase 4 is the depolarization, which we know is where the heart's kind of relaxing and stuff, letting that blood kind of flow back up. It's that slow sodium channel, calcium channels, it's leaky to sodium. Phase 3 is repolarization. It's like K influx, that potassium influx. So the cardiac pacemaker dominance. This is your intrinsic firing rates, like we discussed earlier. The SA node being 60 to 100, the AV being 45 to 60, and then KG's 15 to 45. Like I said, the SA node is primary. It's your number one pacemaker. It does all the hard work. It's got a really fast depolarizing rate. It's faster than a calcium link. Other backups, they gradually depolarize the rate and then gradually kind of leak that calcium out. Potential terms, this is your refractory period. We've already seen earlier where it goes up, hits that potential, it starts to relax. This is just your refractory period right here, we're starting to slow down, kind of relax back to its normal state. Now you got some dysrhythmia generation, some abnormal genus, so that's the imbalance of the sodium in the body. And it can also be it could affect this phase 4, and that's usually referred to ectopic focus. As an example, with a Purkinje fiber where it's kind of like abnormal. Almost an analogy to think about, it's like a one-way valve. It's like the budgies and stuff, bloody red, so it's like your left and right bottom branch blocks. Where they're located at is kind of near Purkinje fibers. If you see a Burner branch block on a 12 lead, or even just regular 4 lead, you'll see a very white QRS complex. Here's another example of that circuits where it's kind of blocked one way and it doesn't fully come through, and it'll kind of relocate and move to another area. So warning, some anti-dysrhythmics have arrhythmic properties. In other words, they can cause dysrhythmia too. As any medication you take. You can take a medication to treat and fix a certain problem, but sometimes it can cause the same problem you're trying to prevent. So if you are constipated and you take stool softeners, too many stool softeners can cause you to be constipated. Yes. Same way with any type of medication you take. You're trying to prevent one thing and still cause the same earlier. I've done it with Zofran, trying to prevent vomiting. Give Zofran still causes them to vomit even more. It's a simple side effect. Not all medication does that, but it can happen. This is something you gotta be mindful of. That's why it's important to treat your patient, look at your patient, and not just assume that something's fixed just because you give medication. This way, it's always a precaution, it's always a warning. The HAA recommends, this is our classifications. It describes the way of supporting evidence, but not the mechanism itself. So you got class 1, class 2A, class 2B, intermediate, and then class 3. And here is Greg Williams classification. You got class 1, that's in 3 categories, 1A, 1B, and 1C. You have class 2, class 3, class 4, and miscellaneous. Like I said, this describes the description of mechanism, not evidence. So sodium channel blockers. Does anybody have an idea what a sodium channel blocker is?
Like as an actual medication?
Sure.
Or what it does?
Yeah, medication, either or.
Lidocaine? Lidocaine is sodium channel blocker?
Lidocaine is a sodium channel blocker. It also can be referred to as anti-arrhythmic.
Yep.
So that's another way to look at a sodium channel blocker. Like I said, the whole purpose is you're decreasing the sodium movement. So what you're doing is you're blocking those sodium enzymes and ions from going into the heart. That's the whole purpose of, like I said, it's blocking. So it's like you're putting a barrier up trying to prevent those specific conduction, and via TSU with fast potential, like in Purkinje fibers. So you're trying to slow that sodium ions from going further down to the heart. But it typically ignores the SA node and the AV nodes because those are what we call more of a slow potential. You usually see this when indications is usually ventricular dysrhythmias. So here are some examples of some class 1 agents. You can refer this to your notes, but promethazine is an anti-arrhythmic. It usually treats PTAC, tachycardia. Norpace, its specific function is to slow down the heart rate, especially for abnormal electrolytes in the body. And Quindex is also the same effect as an anti-arrhythmic, can be treated for AFib or A-flutter, and it kind of helps with that fast or irregular heart rates. That's it. So it decreases the repulsation rate. It can widen the QRS and QT intervals, so it may produce torsades. You probably won't, we don't carry this medication in the field, but somebody's taking this, what should you do for assessment-wise? What's something you want to at least keep mindful when you want to assess a patient? What do you want to do for the patient, or at least try to monitor wise?
How wide the QRS is?
Right, so you should at least do what at minimum?
At least 4 lead.
At least a 4 lead. Some class 1B agents, lidocaine, one you mentioned. We don't really use lidocaine to treat heart anymore. That's not in our protocol. We typically use it for a local anesthesia, but it used to be in our protocol. We used to carry a bag of lidocaine when I first started. All these are pretty much Toracad, the Mentolix, and the Dilatin are also very similar when it comes to lidocaine. Lidocaine used to treat VFib or pulseless VTAC. Tordad usually treats some type of ventricular arrhythmia. Mestic treats like abnormal or irregular heart rate, and technically Dilatin, its main classification is an anticonvulsant, so it's used for seizures, but its secondary classification can be used for cardiac dysrhythmias as well. And that usually can help like an irregular heart rate pretty much. That's it. All you do, this medication is just slowing the conduction through the ventricles. It's not trying to do nothing too crazy. It increases the rate of repolarization, and it reduces the heart workload, the octavity. It's trying to slow down the heart because it's working too hard. It can be effective for the ectopic vulgi. Like I said, it's got other uses. Like I said, lidocaine has more of a look. We use it really mainly for local anesthesia, mainly if we're drilling somebody. Some class 1C agents. Like I said, they slow down conjunction through the ventricles, to the atria and the conduction system. Decreases the repulsation rate and increases contractility. And it's a real elastic training drug. We don't really carry some of this medication is discontinued in the US, but Camicor, it's used to treat AFib, A-flutter, some PSVT, which is, I know we haven't covered yet, but it's a paradoxical supraventricular tachycardia, which pretty much is a sudden increase of a rapid heart rate. This usually originates in the upper chest, kind of near your aorta, or your atria. This is also very similar. It treats AFib and it can treat PSVT. Beta blockers. Y'all's kind of young, but I don't think y'all take any medication. Does anybody have any idea what a beta blocker is? Any medication wise? So a good way to know about it, we'll cover in a second, is looking at one of the suffixes. We'll show the medication on the next slide. But it's a beta-1 receptor that in the heart attaches to the calcium channels. And gradually, with the calcium influx, it kind of helps gradually kind of slow it down. So the beta-1 blockers increase that calcium. So it's kind of similar to a class 4, which we'll cover here in a little bit. The whole point is just blocking that calcium, trying to help with the heart rate, trying to help slow it down. So here are some examples. If you look here, this is a good example of beta blockers. LOL. If you see that as a good, like, hey, that's kind of, a lot of people would take propofol. I don't know if that's the generic name, I can't think of the trade name right now. But all these do the similar thing, they slow the heart rate down. Because you're trying to block all that excess calcium. This one specifically focuses on adrenaline, which is something actually produced in the body, which you know adrenaline increases your heart rate, increases your blood pressure and stuff because it's an automatic response. But it can be used to treat hypertension. Some people use it to treat angina, and some people use it to treat migraines. Think about it, migraines is just an increase of blood pressure and blood in your head, so you're trying to help slow that down, so you're trying to help with that migraine. Similar to acebutolol, it also slows the heart rate down and it relaxes the blood vessels, so it can help improve blood flow. Like when you wash your dishes or you like got a water hose on, if you turn it wide open, you got all that force coming. It's really nice, but sometimes you can't like wash your hands because of how much pressure, so you want to slow it down. Same way what it says, it's just slowing how fast the heart, how that blood flow is going. You just want to slow it down the best you can. And emulsol, it can be used to treat SVT, hypertension and tachycardia, and some hypertension emergencies. The only thing that's different between these two is this one has a half-life of 9 minutes. So this is more like something we carry similar like adenosine. This is more like you got more critical patients, so you want to use this when you don't have it feel, but this is used to treat like SVT because it works fast, but it's got that slow. You got a very quick half-life, so that's why it's important to have a good IV access, typically up here in like the left AC because it's closer to the heart. The faster you get in, the faster it works. Class 3, so you got your potassium channel blockers. They decrease that potassium influx during repolarization, so it's just blocking that potassium from coming in. It prolongs repolarization and it extends effectively to the refractory period. So this is no longer part of the US. And it's called Mertadolol. It was used to treat VFib or some type of tachycardia, but not anymore. But that was just, it's like it's saying it's just blocking those potassium receptors from coming in. You're just trying to slow the heart rate down. So it's no longer in the US, but it's just something to make a note of for testing purposes. Questions, concerns? I noticed a lot of information at one time, so it can be overwhelming, but it's just pretty much like it is. You're either, most of this is just treating really either slow heart rates or really heart rate or fast heart rates, all because it's just physically working on those electrolytes in your body. Class 4, calcium channel blockers. We carry cardizem. Has anybody seen cardizem get given in the field? Yes. What's cardizem? Do you know?
Like, besides the calcium channel blocker? Normally you give it if they have a fast heart rate. Gotta be careful with the blood pressure.
Why?
Because it's gonna drop it.
So, some contraindications is hypotension. So if it's too low, but they have a really fast heart rate, are you going to give calcium? You going to give cardizem, or are you going to hold it? Or are you going to try to do something first?
Give a fluid bolus and then try and get that blood pressure up.
Yeah, I've done it. You can do a fluid bolus, try to get it up some. You can also call a doctor and get orders and see what they recommend. But if they're hypertension, they're probably going to try to get the fluid up first. Try to get their blood pressure up first. I would not recommend doing push dose epi because your heart's already working overtime already. So now you're adding another stimulant to it.
Yep.
So now the heart's even in more overdrive because you're trying to fix the blood pressure. Fluid challenge is very safe. I said you might be mindful of some CHF patients, but at the end of the day, a little bit of fluid for a short amount of time is better than holding it because you're worried about putting in fluid overload. We don't keep patients that long. And so we don't have to worry about giving too much fluid. We'd rather get their blood pressure up some and fix their heart rate because a high heart rate can cause worse problems in the future. Yes, Nephrine does not work on the heart.
Like most of the times I've seen cardizem given, well the times I've given cardizem at the hospitals normally for like AFib, AFib, RVR.
This kind of works as a vasodilator. It only kind of blocks some of the calcium ions from going into the heart. Most of it kind of open up, but it doesn't specifically work on the heart. That's why that note's there. It's just kind of focuses more on the ions and kind of help the vessels so much, but not so much on the heart itself. Here's some of your vascular agents. Adenosine is naturally produced in the body, decreases that calcium influx and increases that potassium influx. It's a second messenger pathway. It's high polarization of the membrane, decreases cotton velocity and slow potentials. Does not affect on fast potentials. There's some side effects, but it's short lived. Does anybody know when it comes to adenosine? Does anybody know dosage for adenosine?
6 to 12.
What was that, Kate?
It's 6 to 12, but some places still do the 6, 12, 12.
Okay. Now, it's 6, 12, and 12. What's something else you gotta be mindful when it comes to adenosine?
It can cause an arrest.
Technically, it does. So when you push adenosine, there's something you want to put on the patient first before you push it.
Pads.
Pad, because you'll see it sometimes where the heart will kind of go to like a sicily aspect before it kind of comes back, so that it'll make you really nervous for like 30 seconds. But something else, it's got a really small half-life.
Mm-hmm.
So it's like 3 to 6 seconds at most. So trying to push the adenosine really fast, that's why I recommend doing left AC or better if you can. Like FC is pretty much what you want because it's the closest way to the heart. You want to push it fast. Now adenosine for counting comes in a 6 milligram little flush itself. That's the thing. You just said it's 12 milligrams, right? So how are you going to do 12 milligrams if you got 2 separate flushes for it?
You have to pull it up into a syringe, a flush or something.
Some people use it, what they call a four-way cock stop, where you can attach 2 things at one time, push, open it, push it, and slam it. What I've done is I put it in a bigger syringe where I push all 12, and I've either had somebody squeeze a bag of fluid as I'm flushing it to try to help slow it down. Now, if you don't have access yet, what's something you can do in the meantime? What's something you can tell the patient? Very simple. Something you can tell them to do.
Vagal. Try and get them to vagal.
Try to get the vagal down. Tell them like, hey, act like you're trying to use the restroom. Try to just kind of push down. I've actually had a guy with a heart rate 186. About to give adenosine. I was like, bud, just breathe for me. I'm about to do an IV. And he ended up breathing so hard, he vagaled himself down because he was scared of the IV and fixed his heart rate. Before I could push medicine, I was kind of disappointed, but yeah, but it is what it is. He fixed himself. He was doing cocaine. His mother had just died. He was a little drunk. He was doing some cocaine. He was a little distraught. But the IV, getting scared of the IV, he took a deep breath and he fixed his heart rate. But it's very short half-life, 6, 12, and 12, and sometimes it will not work. So you have to be mindful of that. So you have a secondary option. Do you know what your secondary option for treating SVT is?
Cardiovert.
Okay, medication-wise, before you go to
Medication
HSC.
wise.
If you treat SVT, what's your second medication-wise?
Is it Amy?
Amiodarone is not for that.
Cardizem.
It is Cardizem. You go to Amiodarone, like it's kind of like a last resort, but yeah, you go to Cardizem next. You know your dose for calcium, Cardizem?
Is it?
25 max of 25?
I know it's a max of 25.
But I don't know if it's for the
Is it 0.5 milligrams per kilogram? Well, a max of 25.
Yeah, so yeah, it's weight based. 25 milligrams per kilogram, max of 25 milligrams. What's your second dose? I think you got your protocol. You look real quick. Send your protocol. You little book right there. Your little pamphlet.
I'll probably get it right here in this
Or
real
you can
quick.
check your notes real quick. Anybody know the second dose of Cardizem? You want to tell them while you're looking?
0.35.
0.35 mg per kg. Now, if you have a patient who's 250 and it's 0.35 mg per kg, what's their dosage?
What was the question? Sorry.
If you got a patient who's 250 and you've already done one dose, and you about to do your second dose, how much are you gonna get for the second dose?
25.
Exactly, 25. Because we only carry 25 of drug anyway, but your max dose is 25 milligrams. So digoxin, so cardiac glycoside inhibits, we don't carry digoxin, that's something to make note of. It inhibits potassium, calcium, TC pump. It increases the intracellular calcium and sage pump. It also increases contractility. It decreases AV, conduct velocity. So typically you see patients who take this, who they be treated for the CHF and the AFib. Not only does it treat that, it also has a diuretic in it. You know what a diuretic is?
Like fluid pill.
Yeah, a little bit, just helps them get that, because keeping so much sodium, you wanna get that fluid off of it, because they're retaining fluid. Because heart failure is pretty much just a backup of blood into the rest of the body, sometimes to the lungs or to that, into cellular space. Antihypertensives. Like I said, this is where your diuretics come in. You see this a lot with CHF patients because they're retaining so much fluid, so much sodium, you're trying to get it off of them. So you also see some beta blockers in here, some ACE inhibitors, calcium channel blockers, and vasodilators. When it comes to vasodilators, what do we carry in the truck? Nitroglycerin. What's your dose for nitroglycerin?
0.4.
How many can you give?
As many as you need.
As many as
As
you
long as the blood pressure is above 110 systolic.
That's another one we give. There's another nitro we give.
Nitro paste.
What's your dose for nitro paste?
Half.
Is the 2 inches right?
You got, what was that, Fifi?
2 inches? Well,
That's one of them. It's 3 different dosage. You got an inch, you got an inch and a half, you got 2 inches. So do you know do you know when to give each one, which specific dose? You know what you're looking for? Specific vital sign.
You gotta do with the blood pressure.
It's the blood pressure. So if systolic is 100, you do an inch. If it's 150, you do an inch and a half. If it's 200, you do 2 inches. So a little paste, no matter how much you spread it across, you make it about this long, it's still gonna be 1 inch. Comes with a little sticky little paper pad. I'd recommend writing on that pad first before you try to place it on the patient, because it's not gonna write well, and you're gonna be hurting somebody putting that force. Trying to write on, like, oh, I forgot to write 2 inches. So I'd recommend writing that paper first. It's gonna be backwards. So when you look at it, it'll be backwards. So when you place it on it, it'll read properly. So you write on the blank side, doesn't have any little tick marks on it, nothing. Just, when would you give nitro paste? Other than just chest pain?
When you can't use the label.
Okay, so that was one. Now, if typically when we give nitro paste in our protocol, is specifically for those fluid-low patients, the really bad CFH patients who are not really breathing well. So if you're CPAPing a patient with an elevated blood pressure, because you got nitro, gotta have a decent blood pressure, you do technically, if they can tolerate it, like I said, if they're conscious, you can do a sublingual, then put the CPAP on somebody, and then do nitro paste. It's not gonna hurt them. So the worst case for nitro paste housing is topical, right? So if it starts looking bad, swap it off of them. Can't get that nitro tablet back, but you can take that nitro paste off. Keep all of them. So typically that's why we usually give the CPAP. So we can, if you're trying to open them up, you're trying to vasodilate them, help them breathe better, try to help move that stuff around. So blood pressure is equal to CO times PVR. So your cardiac output, your SV times your heart rate, and your PVR is equal to your absolute. So here's your cardiac factors and your circulating volume, the heart rate and contractility, rather it's beta blockers, CBCs, or the anadrenics. So you got your salt and your aldosterone versus your ACE inhibitors and your diuretics. CBC is a calcium channel blocker, and then you got your central acting anadrenics, and then you got your ACE inhibitors. So sometimes this can cause this, sometimes cardiac factors can affect specifically the circulating volume. blood pressure is equal to your CO times your PVR. So your hormones, your vasodilators, your ACE inhibitors, your calcium channel blockers, and then you got your peripheral sympathetic system, so your alpha blockers and your beta blockers. You got your CNS down here, and you got your local active peripheral acting analgesics. So your alpha blockers, you got your stimulant alpha receptors, which is usually in correlation to your hypertension, and your block alpha receptor, which is hypotension. So those two specifically treat these specific. Some patients do take medication to fix low blood pressure. Doesn't happen all the time. Most of the time we treat hypertension because of diet, genetics, just how if you have heart disease or not. So here's some medications for you. I'm not gonna try to pronounce them, I'll be honest with you. Do some research. Like I said, we don't carry this in the field, but if you see it in the patient's house, if you do some research, it might give you an idea what's going on, what they might have took, especially if they took too many, and their symptoms can correlate to their medication. Central acting adrenals, so you got your stimulant alpha receptors, inhibit alpha stimulation, hypertension, clonopin, and methadone. So there's some peripheral acting analgesics, Zeppelin, inhibits the release of any diminishes, any stores. It leads to hypotension if you're not careful, so you're trying to bring that blood pressure down, and it has the side effect of depression, which also diminishes serotonin. Serotonin knows what makes you happy. You bring besides dopamine. Some other side effects, you might have some dry mouth. Patients always complain about dry mouth, always want something to drink. It might be drowsy, it might be a little lethargic, it might be because they have somewhat of a sedated effect, it might be constipated. You can cause orthostatic hypotension. How do you check for orthostatic hypotension?
Take a blood pressure with them laying supine, and then have them sit up.
Yep.
Check again. Have them stand up. Check it again.
I had a guy who passed out because he had low blood pressure. He was laying on the ground and he felt better. He sat up and immediately passed back out. Some people recommend Trendelenburg. We don't do that anymore. But fluid challenge, keep them supine, keep them somewhere comfortable where they can talk to you. That's fine, just to get them to the hospital. Less common, you might have some headaches. There might be some sleepless. Yes.
What's the most commonly used adrenergic in the field?
This one, simply. That's what most people typically take. If they do have kind of like somewhat of a blood pressure issue, that's usually what you usually see. They might have a different name. Medication always goes by different names, trade names, or generic names. That's one of the most common ones we see.
And are these for low blood pressure
High blood pressure.
or high blood pressure?
But most of the common ones you do see that's for high blood pressure is what I take lisinopril.
That's
Lisinopril is
So
the one
what's
most common.
the one you see?
Lisinopril.
Yeah.
Yeah, this is another one, but most people around here typically take lisinopril because it's been around for so long. It's one that has the least side effects. The only biggest side effects when it comes to lisinopril is angioedema, and that won't happen sometimes until I had a guy who had taken lisinopril for 15 years, all of a sudden had an allergic reaction to it. Body's weird. So this is how your ACE inhibitor works in your heart. Take the medication, ACE inhibitor, and it turns into the analgesic 2. You got some vasoconstriction, which increases blood pressure, and you can stimulate that aldosterone through some even H2O. It helps resorption, so you're trying to help increase that blood pressure. So analgesic 2 is a vasoconstrictor. It constricts blood vessels, increases blood pressure. We don't have, what is a vasoconstrictor we carry? Epinephrine, yes. We don't use it for, we treat it for more critical patients, but we don't always just drop straight to epi to treat blood pressure. If we are treating it, what's your dose for the epi you want to treat for low blood pressure in your critical patients?
Is it the push dose?
It is the push dose epi.
9 mLs of something and pull up 9 mLs of something.
Alright, so we know 9 to 9. So you waste 9 mLs of more saline, and then you draw up the epi 1 to 10, and then you'll have a 10 ml syringe that is 1 to 100,000. We do this because if you do it the other way, you get confused and you can misdose somebody. So each dose for 1 ml is 10 micrograms, and then you'll have 100 micrograms in that one little vial, in that one little 10 ml syringe. And then you want to push it every 2 to 3 minutes until you get a blood pressure that titrates at least 90 or better. It's more of your critical patients. That's more of your like it's circling the drain, and everything else isn't worked yet. So that's when you want to go push those epi, because at the end of the day, you still want to try to increase that cardiac output. But you got to think the heart's already not functioning well. Already it's already trying to compensate. So you got to be mindful of it, because you could put too much workload on the heart and cause a bigger issue. So they also increase the SVR afterload, and they kind of block the effects decreasing this afterload. Some of your ACE inhibitors, they secrete from adrenal glands, causes sodium and water reabsorption. They increase blood volume and increase preload. The ACE inhibitors block this, decreases the preload. So this is some of this converting enzymes, and this is some new medication, Cinepril. It's pretty much blood pressure. It's what you're doing. You're trying to help increase that blood pressure. This is what I take because I have high blood pressure, probably because of stress and genetics. But a lot of your Pril, if you see that suffix like we looked earlier when it comes to the beta blockers, you'll see these Pril. They call them the Pril sisters. A lot of people typically take some of these medications to help kind of with their blood pressure. So if you see that Pril, normally got some type of hypertension. That's it. It can be used for, sorry, my apologies. So that's just, maybe it would be blood pressure, it can be heart rate, but most times it would be blood pressure. Calcium channel blockers, angina, which is just pretty much chest pain, tachycardia, and then hypertension. So we don't treat hypertension in the field. That is not our job. But we do try to fix other problems like heart rate or low blood pressure. Yes.
So, like we were talking about earlier with the angioedema, is there anything that can reverse that? Like, is epi gonna reverse that, or?
So yes, we do use epi. With angioedema, it falls into your anaphylaxis protocol. So it's technically under there, but
Will it fix it, or?
it can help improve it. It won't fully fix it. The hospital actually uses TX8. Yes, it's not our protocol, but the hospital uses TX8 to fix angioedema. But you follow your anaphylaxis protocol. So what's your first line defense of anaphylaxis?
I am epi.
Which epi?
The little one with the purple top journaling,
Okay, what's that dose?
point, I don't wanna say, 0.15 to 0.30, but I'm pretty sure the 1.5 is for kids and the 30 is for adults.
So it's
0.3.
0.3, 0.5. And is it epi 1 to 1 or is it epi 1 to 10? Because you got two different epis.
Wait,
Epi 1 to 1. So you think about pediatric dose. Most pediatric doses. If you're doing 0.15, that's a pediatric dose. Well, it's 0.3 to 0.5 for anaphylaxis. We also carry Benadryl, and you also carry, you can use Salmeterol, and another thing you carry, a lot of people forget about, albuterol, because you gotta think about it. Angioedema is swelling in the tongue, now they're having difficulty breathing. So you might not hear stridor, but you wanna at least try to open them up because it's a vasodilator. Now I mentioned you already give them a vasoconstrictor, so you wanna help combat that. You're trying to bring that swelling down, but you also wanna help them breathe better. So we're trying to do epi, trying to do Benadryl, trying to do Salmeterol, trying to do albuterol, trying to help fit this. I've had really bad angioedema where by the time I got to the hospital, it had pretty much closed up his entire airway. I couldn't see in the back of his mouth anymore. But I had given a dose of epi 1 to 1, and then I was working on the 2 doses of epi 1 to 1, and then I was working on the next dose, which is epi 1 to 10 IV. But it's also still a low dose. So here's some calcium channel blocker sites. So Cardizin specifically works right in the heart. So we don't carry this anymore, but it works similar. So Cardizin increases the automaticity and conduction in SA and AV nodes, decreases myocardial contractility, decreases smooth muscle tone, and decreases PVR. Like I said, the nephrine also decreases smooth muscle tone and decreases PVR. And what we say is a contradiction for Cardizem, blood pressure. And what other is a contradiction of Cardizem besides blood pressure? It's an underlying rhythm. Give you a second, look it up. You check your protocols.
Is it WPW?
Yes, WPW is one.
Feedback.
Yes, but what kind of VTAC specific? Yeah, VTAC, yeah, because it's widely irregular. So yeah, so WPW, hypertension, and well, Parkinson white. So some side effects, you can cause hypotension. That's why it's contraindicated, because 1 + 1 = 3. So if you already got low blood pressure, you give something to bring the blood pressure down, then you got to fix the bigger problem you created. Some palpitations and tachycardia, because there might be some regular heart rate. Some constipation, nausea, it can happen. Doesn't always happen, but it will happen. Maybe some rash, maybe some flushing, maybe some peripheral edema. Like I said, Cardizem is one of the biggest ones that we carry on the truck. This is no longer in the US, but something to be mindful of. And Variparin, which is another medication, some people take it home if they can't take Cardizem. This is just an example of a diuretic site, how it works in the kidneys, follows this tube down to the liquid inhaler, up to the distal tube, down to the conductor duct. Mechanism: water follows sodium. Osmosis. 20-25% of all sodium is reabsorbed into the bloodstream in a loop of handling. That's why patients take dialysis, because urine is filtered through their blood. That's the whole purpose of dialysis, because they can't fully get rid of that sodium. So that's why they go to dialysis several times a day, or several times throughout the week if you go to the clinic. But there's also one you do at home, and that's like daily. That's up to 8 hours. That's a peripheral dialysis. 5 to 10% in distal, 2 and 3% in collecting ducts. If it cannot be absorbed, it is excreted in the urine. So that's why you take the diuretics. If you can't get it off through the blood, you pee it out. So decreased blood volume equals decreased prelude. So side effects of diuretics, there's like also you might have decreased sodium, decreased calcium, decreased potassium. They might feel like they're dehydrated. Check your vital signs: anemia, MVD, nausea, vomiting, diarrhea, dizziness, and elevated sugar, so that hyperglycemia. Questions, concerns? Are those in anybody? Yes.
You're not losing me, but earlier we were talking about Y complex type irregular tachycardia and contraindications for Cardizem. So aren't all ventricular dysrhythmia or ventricular tachycardia is regular, or is it talking about a different kind of irregular?
Irregular. So that when you look at VTAC, like probably more like VFib or post VTAC or your sides, something got to be mindful, because it's irregular and not fully attached to, or it's just misfiring. Some other examples of your diuretics: some loop diuretics, potassium, one that kind of keeps you from peeing out potassium. That's why it's potassium sparing. It kind of holds onto it. That's the difference between some of these. Some of you trying to get rid of too much potassium, especially with your diabetics. But this one's potassium sparing, so they don't have to take a potassium supplement. Some vasodilators, they directly release Aristotle and smooth muscle and decrease SVR and decrease afterload. And some side effects could be some reflux, tachycardia, could be possible renal failure, that's one of your critical cases, and toxicity, agitation, hallucination, etc., which is more usually kind of affects your actual mental state, your CNS. So vasodilators, we don't carry none of these, but vasodilators, you know, you open the blood vessels. The main one we carry is nitroglycerin. Drugs affecting hemostasis. textbook for here. Try to reference this because I don't have a picture of it. There's a picture here. It's just how the platelet adhesion is just attaching to blood vessels and stuff. So coagulation and cascade. It's reproduction following the components of cascade. So thrombin, fibrin, and plasmin. Jazz, if you want to stop, you can stop.
You don't wanna end it?